So I'm just going to jump in, and feel free to just come off mute if you have any questions. And I think the conversation we were just having around social determinants of health is an important one for the work on food as medicine. But just to kind of level set, this is probably the most sobering graph I've seen in a long time. And what you're seeing on here is the healthcare spending per capita on the x-axis and the life expectancy at birth on the y-axis. And as you can see, we have countries comparable to the United States in blue, and then the United States healthcare spending in green. And what you're seeing here is that the healthcare spending in the United States is 2.5 times that of other comparable countries. However, our life expectancy is worse than any other peer country. Not to mention there's other contributing factors, such as Americans consume more calories than any other country. That is a fact, and have higher obesity rates that explain about half of the lower life expectancy at the age of 50. So we are spending a lot more than other countries, but we're living shorter lives and unhealthier lives. So our spending is not working for us in regards to what we're trying to achieve. That means we need to do something different. This is, I'm preaching to the choir here, but the Aspen Institute puts out a report on food as medicine research action plan every couple of years, and back in 2022 really showed how the evidence has emerged in regards to food and its relationship to health. And you can see that it affects all of the organs, including our vascular system, our brain health, our kidneys, our liver, bones, and usually these are co-occurring issues in the same individual. The challenge has been that 9 out of 10 Americans essentially don't meet the recommendations for fruits and vegetables. 10 out of 10 know that eating more fruits and vegetables is good for you, but only 1 out of 10 seems to be able to meet the recommendations. 9 out of 10 Americans have excess sodium intakes. And when we look at obesity rates, they've tripled from 15% in 1980 to more than 42% at this time. When we look at other food groups, which fall in the healthier category, like whole grains, we have a similar issue that we see. So generally, our communities are just eating a lot of food that we shouldn't. And that takes me into food security or food insecurity. But food security is a social determinant of health, and it's measured at the household level. And the definition for the USDA Economic Research Service is it means access by all people at all times to enough food for an active, healthy life. So it really is measures just one dimension, which is access, and also measures just whether it's enough. And typically when we look at electronic medical records or what is being screened, it's this 2-item hunger vital sign that's usually used in terms of rapid screening in healthcare settings or community settings. It's a validated screener by Hager, Quigg, and Black. It's been around for a while now, so I would say about 15 years or so. In addition, a more recent screening tool has been around nutrition security, which really goes into a little bit into the diet quality. It's not a measure of diet quality. Again, it's measured at the household level, but it gets to access of healthy, safe, and affordable food. So this is the one construct that we have more recently that's about improving access to healthy food. And there's a couple of screeners out there. There's one out of Tufts that's out there on nutrition security. And then there's one that's validated out of the Center for Nutrition and Health Impact that's available for screening as well. And when we think about food insecurity and diet quality and how all of these are related, this conceptual framework really puts it well, where essentially households that are food insecure engage in what we call coping strategies and disordered eating patterns, and they end up eating foods that are ultra processed, energy dense, but nutrient deficient. And that's because they're eating foods that are available to them, readily available, shelf stable, and cheap. And those are the kinds of food that fall into this category. And what that does is over time predisposes those same households to chronic disease, impacts their employability, increases healthcare expenditures, and probably the one that puts them into this cycle is addresses their, they have spending trade-offs. So this week I'll buy groceries, but I won't pay my utilities bill, or so there's co-occurring social needs and mostly in individuals. And one of the things that we're also seeing emerging in the literature, that patients who have multiple co-occurring needs, actually their healthcare utilization, there's a threshold effect. So patients with 3 or more social needs have greater probability of having ED visits, number of days hospitalized and such. So when we work with health systems, we encourage that they screen for multiple social needs. Even though they might just have a robust plan for food security, it's important that we understand that patients coming in with multiple social needs actually have a greater risk for poorer health outcomes. One of the other challenges, which I've articulated below, is that the conversations around food system, as well as nutrition education, is largely invisible in our schools, our medical schools, nursing schools, parenting programs. So it's unlikely that, it's unsurprising, I would say, that we are living in an ecosystem where these choices are being made, and also that the financial stress that really triggers the food insecurity is largely unaddressed as well. And concurrently, the same households that are food insecure are also surrounded by what we call food swamps, which is high density of fast food restaurants and ultra processed foods. And there's also a huge bombardment, if you will, of related messages to consume those types of food. The last thing I'll say on this slide is the middle bubble here on stress. And this stress is, the cognitive stress is chronic because of the financial insecurity that these families struggle with. And what that essentially does is that it impacts over time executive functioning and also participation of these members within these households in their own healthy lifestyle behaviors. And so one of the things you will see in the literature is that, well, these weight loss programs or lifestyle interventions just didn't work in certain populations. Well, it didn't work in certain populations because studies have shown that when you are under chronic cognitive stress and your executive functioning is impacted, it reduces your likelihood of engaging in lifestyle interventions. And so breaking this cycle becomes important in regards to addressing the stress as well. So how do you break this cycle? One strategy, this is at the very top, is government assistance programs like SNAP and WIC. They're very effective. However, many of those who are eligible do not enroll in these programs, even though they're probably one of the most effective methods of addressing food insecurity. And many of them do not qualify. If you're undocumented, you won't qualify for SNAP. And they're the ones who are most food insecure. So we need to think of solutions that can help address these needs in different ways. It's not going to be a one shoe fits all. So we're going to have to think about how do we bring different shoes to the table. So this is the question that we've largely been trying to address, is how can we create sustainable solutions to address food insecurity, improve diet quality, and address diet-related chronic conditions. So that's the work that we're doing at the Center for Health Equity. I'm not going to go into this. You're welcome to visit our website. But really, the only thing I'll say here is that the approach we're using is really building a strong infrastructure through partnerships and systems design to do this work. So for example, in the space of food as medicine, we have health systems and community organizations that are engaged in this space. Well, we want to first make sure that they have the capacity and the readiness to engage in a meaningful way, upon which then you can set forth the right data insights and generate the right data insights to then inform your intervention. So I'll talk a little bit more about that in a minute. Our focus at the center is on social and structural drivers of health, and these are the three areas that we are largely engaged in. And I'll focus the rest of the next 5 or 10 minutes talking specifically about our Healthcare by Food initiative in partnership with the American Heart Association. So this is a national initiative. And to give a little bit of the background, the impetus of this initiative is really behind this one slide, that over 90% of the $4.3 trillion in annual, it's $4.5 trillion this year, in annual healthcare costs are spent on medical care of diet-related chronic conditions. Very few of those dollars go actually towards prevention. And so the question is, can some of those dollars go towards healthy food to be a covered medical benefit? So if you went to the doctor and you're diabetic, in addition to getting a prescription for metformin, wouldn't it be nice if your doctor also gave you a prescription for healthy food? And the only side effect would be that you felt better. So that's sort of the premise. And the premise comes from this very large policy shift that we had starting, which was optional in 2023, but has been mandatory starting 2024 from CMS, that requires hospitals to essentially screen across 5 domains of social determinants of health. These are 5 domains. One of them is food insecurity. And then there are new HEDIS quality measures around the screening and response. This shift has essentially led to us as a country thinking about, well, if we're screening, what is the right response to really address this need? But to get to this, pie in the sky, right, of healthy food to be a covered medical benefit, that means your insurance company is paying for it. We have to look at what has happened in the past in this space. And our biggest and best example is the diabetes prevention program, which showed that essentially engaging in DPP reduced the incidence of diabetes by 58% as compared to 31% for metformin. But even after this lovely RCT in 2002, which showed clearly large demonstrated impact, it took insurers about 12 to 14 years after publication of this study for the DPP to get routinely covered. How do we accelerate this work is what we're trying to do in the Healthcare by Food initiative. It's funded through the Rockefeller Foundation, and the initiative is essentially focused on designing and scaling programs and getting them to the point like DPP for it to be a covered medical benefit to improve health equity, and lower healthcare costs. So it's a very ambitious goal, no doubt. And this was the presidential advisory from the American Heart Association that we had the opportunity to collaborate on, which really outlines sort of the definition, the fundamental definitions around what is food as medicine. In a nutshell, what food as medicine is: provision of healthy food to manage, treat, or prevent specific health conditions in a way that's integrated with the healthcare system. So there's three main buckets: medically tailored meals, produce prescription programs, and medically tailored groceries. Medically tailored meals is essentially prepared meals going to the homes. Produce prescription programs is you essentially can pick up or get a home delivery of a box of fresh produce. And then medically tailored groceries is essentially you have like a card, like a debit card that has money on it that you can use to only buy groceries at the grocery store. There are many active models of these types of programs available throughout the country. Just in our region, we've put together a program index in partnership with Texas Consortium for Non-Medical Drivers of Health. And just in Houston, there's just in Texas, there's over 60 unique programs related to food as medicine. So a lot happening here. So what are we doing as part of that? This Healthcare by Food initiative. We want to achieve maximum impact in improving health by testing whether these programs are effective or not. So that's sort of the main goal. And we are right now sort of in the first phase. And we want to use what's very much a human-centered design approach. So using lived experience to really drive the work. So doing that initial inquiry, defining, measuring outcomes, again, sort of using it to run these rapid, low-cost experiments to test, and then ultimately we'll be doing those larger trials. We also want to study some of the behavioral economics behind, this is an incentive program, right? So how do incentives work? We found that even with medically tailored retail, people are leaving money on the table at the end of the month. So we want to understand, well, how do these incentives work, can be used effectively or ineffectively as well, because that's going to be important in the long run. And then we want to build evidence through clinical trials. And this is really critical because I'll show you this very clear example that just happened late last year. So there was a study published, a pre-post study of 95 patients enrolled in a food as medicine program that showed a 2.1% drop in A1C levels, corresponding to a 40% decrease in risk of death or serious complications. Wonderful. That sounds extremely promising. However, a subsequent randomized control trial of the same program resulted in improvements in A1C in both the intervention and control group, leading to a non-significant difference between groups. So doing the RCT really allowed us to be able to attribute the impact to the intervention, or in this case, not. There was no impact specific to the intervention. So that evidence is important. And just to orient everybody on sort of where we are here. So in this Healthcare by Food initiative, we've finished the planning period, and we are here doing a lot of what we're calling rapid cycle testing, because we want to understand what is the right dosage needed. If we're seeing food as medicine, we need to know the dosage. We need to know what the uptake is in regards to these types of interventions. What are the learnings that need to be had to really tighten up the formula, if you will? And then once we have done all of that learning, there's going to be these definitive trials, which are your clinical trials, where we'll also assess cost effectiveness and look at implementation and dissemination to ultimately get us to this promised land. So it's a little bit of a ways off. I'm not going to go, I'm happy to share these slides, but these are our members of our group. But what I wanted to jump into is the work we're doing here. So we have right now, through this Healthcare by Food initiative, we have work going on to test out all of these different types of interventions. A high priority group is maternal health, so looking at pregnant moms and following them into postpartum and testing out different models. So there's one model with the Houston Food Bank that's a home delivery of food prescriptions. There's another model where we've partnered with a for-profit and a nonprofit to look at what that partnership looks like. And then we have a medically tailored retail where they get $100 card to just purchase produce at local retail stores. And then we're looking at various outcomes as well as budget impact of these interventions. We have a lot of implementation outcomes as well. We're testing out a lot of different things. We have a chat bot we're testing out on scaling nutrition education, cardholder engagement strategy. So there's a lot of learning. And we have established a mom community advisory group that is informing us every step of the way as well. So this is the model that we're using to do this work. So very much a human-centered design approach. Our community advisory group of moms is guiding us in our pregnant mom cohort, building partnership with the systems, doing a lot of capacity building within the systems, both CBOs and healthcare, and then looking at these outcomes and sustainability. So that's sort of the bulk of the work. We have a core team that's involved in all of this work that's doing phenomenal job. And we've done work similarly in the past where we had one of the largest evaluations of food prescription program in the greater Houston region, which found meaningful decreases in A1C as compared to those who were not exposed to the program. And we also have several pediatric cohorts. This is another population of interest. And we are trying to leverage school-based health centers to see if we can test and do this work, as well as connecting it to culinary medicine as an approach to address child health. So, I'll end by just saying that this is a very exciting time. Because not only do we have the policy support to be able to do this in partnership with health systems, we also have support from the White House as well to end hunger and build healthy communities strategy that was put forth by the Biden administration. And with that, I'll stop. I know this was fast. But happy to answer any questions. But what's exciting, I just want to end by saying this is exciting because we have so much going on in our state. I presented a little bit, like I said, there's 60 different efforts going on, lots of research across lots of institutions. So it's very exciting to be able to share this work. Thank you.